Hello and welcome to the latest in the COVID-19 webinar series hosted by the Royal College of Surgeons of Edinburgh and joint with the Association of Coloproctology of Great Britain and Ireland. I'm Neil Smart, I'm a consultant colorectal surgeon in Exeter and the editor-in-chief of Colorectal Disease, and I'm your chair this evening. I'm joined by a range of panelists from around the United Kingdom, including Nicola Fernhead, who's the president of the Association of Coloproctology, Mark Coleman, who is the chair of JAG and a consultant colorectal surgeon in Plymouth, Ian Jenkins, who's a consultant colorectal surgeon at St Mark's, and Dina Haji, who is a senior trainee in the Northern Deanery and president of Duke Club. We're going to start with a few slides to begin with, and then we'll be taking questions. And we know that there'll be lots of questions that many of you will want to ask. Please use the question and answer function, and we'll start by going over to Nicola to begin the presentation. Nicola, over to you.
Thank you very much, Neil, and also a huge thank you to the RCS Edinburgh, who've once again hosted the second in this combined series. We really appreciate the partnership of working with them over the last few years. So what has ACPGBI been up to? Since we last met on this webinar, we were very much in the position of dealing with surge or acceleration and really trying to prioritize emergency general surgery and the like. But tonight is a different setting. It's about recovery. It's about trying to get elective surgery back on track, looking at reestablishing our diagnostics, especially colonoscopy. A really good time to focus on training and the issues that our trainees are facing, but also to think of some of the wider issues about how we remain connected in a very different world, how we look after our workforce and keep them sustainable for the future, and a little bit about trying to grab the legacy of what we have learnt to deal with in the last few weeks and making sure that we've learned lessons for the future, that we keep what is good and dispense with what is bad. Next slide, please. So this is really just to give you an update on the guidance that ACPGBI has provided in terms of resuming elective surgery. I point out that this is the second update released a couple of weeks ago, and there's some key things which are different to our initial strategy. Some things have not changed. The importance of prioritizing patients properly, assessing their vulnerability, but now thinking also that that vulnerability may have increased or decreased. Increased because actually they might be less well, but also maybe decreased because the environment now is that bit safer for bringing patients into hospital. And that really is the focus. It's largely going to be about environment. How COVID-free is an environment? Because linked to that is the signal that if patients develop COVID-19 and particularly pulmonary complications of COVID-19 in the perioperative period, either preoperatively or postoperatively, then they are at much higher risk of mortality and seriously adverse outcomes. So how have we managed to find a way of providing a strategy, a framework in which to work? The first is to go with what we had recommended all along, the 14 days of strict self-isolation. And interestingly, now NHS England have decided that that probably is the best way to go as well. We want them to be negative on screening questions and also to have had a negative test, preferably within 72 hours of their date for surgery. To bring all of this together is really important. It requires systems and planning, administrative support, and really patient buy-in, and selling that concept to patients both of increased risk and helping minimize their own personal risk by following the isolation guidelines is going to be a really important sell for colorectal surgeons going forward. You'll remember at the last meeting we talked about CT chest. Why have we dropped that? We've dropped that alongside using it as a screening test for all patients having gastrointestinal cancer surgery. And the reason for that is emerging evidence which shows what a very poor test it is as a screening test for COVID in an isolated, screened and questionnaire negative patient. And that's the big difference. We're going to use our radiology services very much to deal with emergency patients and still stand by the fact that an emergency patient having a CT abdomen should still have a CT chest, but in the setting of screening, no longer a recommendation. All of this happens with a lot of multidisciplinary oversight, really being ready to flex our prioritization with capacity and resources, particularly in the event of a potential second surge, and knowing when that's coming and how that should change things. So data collection is going to be really, really important overall. Next slide, please. Research, as always, for our organisation is very important. We have encouraged our members to participate as widely as they can in the plethora of studies which are looking to gather data around surgery, particularly in the time of COVID-19, but also in the broader sense of looking at supporting research in other ways, particularly those in the intensive care setting. We're very proud to be a partner now of Covered Surge and have funded Covered Surge particularly for the colorectal cancer and colorectal interest areas. Next slide, please. In addition to that, we're trying to support our members. There have been a number of initiatives to do this. We set up an early years consultant network task force just over a year ago with a view to launching a committee of early years consultants from this July. We've brought that forward because there's clearly need for support for young consultants in terms of managing how their lives have changed and planning for their futures. And I'm very proud to show you the results of the election announced last Friday, which is our first steering committee. Next slide, please. In addition to that, we're trying to provide access for our members to know about what's going on, to ask their questions and have them answered. And we're now running Access ACP with an expert panel every Thursday evening at 6 o'clock. 45 minutes, no more, but a chance to ask your questions about each of these topics going forward. The next one tomorrow being about laparoscopy in particular. Next slide, please. There's also a time when you really do feel that you want to talk about something other than COVID. And although we'll never be able to avoid the topic, we do feel it's time to bring you some additional education. And so we're investing enormously in bringing you the Edinburgh Fringe. It's not the Edinburgh Fringe, it's ACPGBI's version of it during the time when we should have been having our meeting in Edinburgh between the 5th and the 8th of July. Keep some time free Sunday morning and the afternoons of the Monday, Tuesday and Wednesday, and we hope to bring you some really high quality content on a virtual platform. Thank you.
And so now over to Mark Coleman, who's going to talk about issues relating to endoscopy. Mark, over to you.
Thank you, Neil. Hope you can all hear me. And thanks again to Nicola and the ACPGBI and the Royal College of Surgeons of Edinburgh. As Neil said, I'm a consultant colorectal surgeon in Plymouth, and I'm chairman of the Joint Advisory Group for GI Endoscopy. Now, in terms of, I was just thinking today, in terms of endoscopy, this organization is now in its 25th year. And those of you as old as me know that endoscopy is in a very different place to what it was in 1994-5. And I think in 25 years' time, endoscopy is going to be in a very different place to where it is now. So particularly when I come to aspects concerning the future of training, I think we need to bear this in mind, and I'll come back to that. Now, JAG works with the ACP amongst many other organizations, including ORGIS, pediatric societies, and the British Society of Gastroenterology. And in case you didn't know, we sit within the Royal College of Physicians. So I'm a sort of honorary physician, which is never where I wanted to be in my life, but there we are. Next slide, please. So firstly, in terms of service restoration, there's several things I've highlighted there. The most important thing is that there's no one size that fits all in every endoscopy unit around the country, and JAG is responsible for England and Scotland, Wales, Northern Ireland. We also actually run accreditation services in the Republic of Ireland, and for that matter in places like New Zealand. So we are quite a global organization. But individuals thinking of restoration in their own units need to consider the local resources and conditions. And of course, looking at, for example, PPE, we know that the availability of PPE is variable. What I would say about that as well is it's easy for a colonoscopist like me to say, well, amber PPE should be fine. Patients are being tested, clinically assessed when they come into the unit. But just remember, there's a nurse sitting at the top end of a patient who might be anxious for whatever reason, who might have undisclosed medical problems and want to wear full PPE. So we need to consider these laws of unexpected consequences, if you like, in planning how we go forward. I think teams and workforces are nervous, and some of them have been redeployed, and a lot of them are still in isolation for whatever reason. So just bear this in mind. If anything, if you're involved in things like the team brief, just look around you a bit more than normal and say, is everyone in this room happy? Because there are certainly problems with people's anxieties feeding into potential concerns around the increased possibility of error. So just bear these things in mind. Human factors, teamwork, good team brief, debrief, think about every patient in terms of their risk of COVID. Again, the local availability of COVID testing for patients is important, but also for staff, because some units are developing COVID-free sites or cold sites, off-site in some cases, sometimes in the same unit. And so those safe sites need to be very carefully guarded through the availability of robust capacity for testing patients. And then there's about sort of capacity planning as well around the size of your endoscopy units and the kind of throughput. Everybody's starting to be aware of the number of backlog symptomatic and screen cases that need to be scoped, and we need to bear this in mind. Almost everywhere has gone down the route of Q-fit stratification of symptomatic 2-week wait patients. And I'll come back to that in terms of service restoration. But what's important to learn here is that what we're finding is that this is actually going to be not something that we just do temporarily during this pandemic, but are likely to do in the longer term. Because we know, and Nicola alluded to this last time, that the rate of diagnosis through colonoscopy in the 2-week wait is below 5%. And we've all felt for many years this is unacceptable. And if we can use a means to increase the sensitivity of our tests and diagnose more patients in an appropriate way, then that's a good thing. Again, through all of this, what I just want to repeat saying is the information about service restoration is available through the JAG website, and there are links to NHS England and the devolved nations and to BSG and to other key stakeholder organisations about service restoration. Next slide, please, Ryan. In terms of training, just a couple of things about training in terms of what's happening at the moment and what's happening in future. A lot of our junior colleagues have been redeployed, particularly the physicians have been redeployed to look after COVID wards. Again, we have to consider the availability of PPE and give priority to patients to have endoscopies by experienced practitioners that are likely to get through a reasonable volume of work. And that, I'm afraid, at the moment adds up to a very difficult time for trainees. The availability of PPE, the difficulty with spacing and distancing in endoscopy rooms, the relative lack of staff in some rooms, the anxiety of staff in some rooms, the need to have the most effective and experienced practitioners doing the procedures and to generate as much efficiency and create a safe environment. These are all the reasons why training for a period of time, quite rightly, has gone out the window. Now, I hope to say by today that JAG was publishing guidance on restoration of training, but we're just not quite there yet. Jeff Smith, who's the chairman of the training committee for JAG, is finalizing that document. But just keep an eye on the JAG website, and that will be present hopefully within the next working week or so for you to see how trainees are affected. In terms of the future, again, keep an eye on the website. And my last sort of information slide, next slide, please. What's going to happen in the future? And again, I've alluded to the fact that endoscopy is going to be in a very different place in 25 years' time. Why? Well, obviously, we already know about CT colonography, and that's likely to play a bigger part in diagnosing more 2-week wait patients. And things like capsule endoscopy will also probably have a more significant role in providing less invasive, more acceptable lower risk ways for patients to be screened for colorectal cancer and polyps. And I think it's more likely, therefore, there'll be less of a need for experienced endoscopists, and those experienced endoscopists are more likely to be therapeutic. What is happening right now is that Health Education England are looking to expand their current program, which currently trains for flexible sigmoidoscopy and OGD, into colonoscopy. There is going to be one deanery appointing a training lead for endoscopy to support surgeons and physicians who want to get trained in endoscopy. And I think that can only be a good thing. And if that's a successful rollout, that's likely to happen in every deanery. Some people know about the Peninsular Radiology Academy and other radiology academies in Norwich and Leeds. And that's something, that model that's being looked at in terms of both training and service provision to provide dedicated sites for high volume endoscopy plus high quality training. And at a very senior level in NHS England, that is being looked at as a potential model. And overall, NHS England are looking to fund a significant increase in capacity for both screening and symptomatic patients to have colonoscopy. That is something that you'll know about within the next 6 to 12 months, and I'll leave it there. JAG is unlikely to support any change in benchmarking in terms of what you need to gain accreditation to be a colonoscopist, for example, because we feel the benchmark is a good one, and people should aspire to have that level of skill before practicing independently. As I've said, I think endoscopists are more likely to be specialists, and the question behind that is, should every trainee, say in colorectal, be training towards colonoscopy? And that's probably the most controversial area within training that I can address tonight. And my view is that it's inevitable, because of what I just said, that people will declare whether they want to do colonoscopy in future. And not all people will become endoscopists who are colorectal surgeons. But it's important to say that will also apply to physicians as well. And they understand that fully in my interactions with BSG and through the JAG committee. I think that's about all I have to say. My final slide is questions, but we're going to come back to the end. So I'll hand back to Neil with thanks.
Thank you, Mark. And we're going to move swiftly on to Dina, who's going to talk about some of the issues with regard to training. Dina, over to you.
Great. Thank you, Neil, and thank you to Nicola and the ACPGBI and the Royal College of Surgeons for Edinburgh for inviting me to speak. Next slide, please, Ryan. So I want to just take you back right to the beginning. This was published on the 14th of March by training bodies, by ACIT and all 15 trainee specialty associations, calling trainees to come together to unite in the fight against COVID-19. As trainees, we have lost quite a lot during this period, but rightly so. We have united together to try and deal with the issues that the COVID-19 pandemic has brought us. We have been redeployed to other specialties, we have not focused on training, and we have had to think about resitting exams or postponing exams, thinking about delaying recruitment to specialty training programs and rearranging fellowships and potentially delaying CCT. Next slide, please. So it only makes sense that we are part of the recovery following the COVID-19 pandemic. And we have had a lot of discussions and done a lot of work with the ACPGBI Education Training Committee and the ACPGBI Executive Committee about how that might look for colorectal surgery trainees. And we have come up with 7 key areas where trainers and trainees, alongside our 2 respective organisations, should focus on. And I'm just going to take you through a whistle-stop tour of this. I'm not going to spend too much time on it. We should be looking at the multimodal recovery of training. Surgical training is not limited to just theatre. Yes, trainers and trainees should be looking at resuming operative training. We should be moving away from the dual consultant operating, and trainees should be given the opportunity to participate in operations within the surgical environment. But we should also be looking at recovering training on the ward, in clinic, in MDT and endoscopy. Now, Mark Coleman has already talked to you a little bit about endoscopy, and JAG have made some changes with regards to how those trainees around about the time of accreditation might be looking to get accredited with regards to their key performance indicators. But we should be using this as an opportunity to look at how we reshape endoscopy training for surgical trainees. We should be looking at this as an opportunity to have a level playing field with gastroenterology trainees, and we should all be considered, gastroenterology trainees and colorectal trainees, as trainees in endoscopy. We should not be defined by our specialty. There are a plethora of educational resources available, and Dukes and the ACPGBI together have been working very hard on delivering virtual educational strategies. So Dukes have got an operative training strategy that will be launched later on this month, but we've been working with other subcommittees within the ACPGBI, for example, with the Advanced Cancer Committee, to deliver cadaveric virtual training. There are plenty of opportunities to resume training and resume educational resource on a virtual platform. We need to use this time to be mindful that we support those trainees who are in special circumstances, so those who are shielding due to vulnerabilities, those who are returning from being redeployed, and those who are transitioning at key time points, so those that are going from CT2 to ST3 or ST7 into ST8 or ST8 into a fellowship or consultant post. Consultant surgeons should also be using this time to consider the resources that they have available to them as trainers. Most hospitals have simulation facilities. They should be used appropriately. Things like regional teaching should be encouraged to restart, and Journal Club on a virtual platform should be delivered to colorectal trainees. I think the peri-CCT trainees and the trainees that will be transitioning to consultant practice are those that probably face the most anxieties and difficulties during this period. Peri-CCT trainees have lots of options available to them. JCST did demonstrate some flexibility in how we approach CCT, particularly with regards to the requirements that we need to reach CCT. And I think we as Dukes and ACPGBI would encourage all peri-CCT trainees to have an early, open and honest conversation with their training programme directors about how they may achieve CCT requirements in this time period, and whether they should appropriately extend them using outcome 10.2. Those transitioning into fellowship should have early conversations with their fellowship trainers with regards to the potential opportunities available and delay if necessary. And those transitioning to consultant practice, we encourage you to think about the networks that you are going to develop with regards to your consultant life. Think about mentorship, think about support from your peers, and certainly the Early Years Consultant Task Force will help with that. We hope to launch this in a more comprehensive statement at the end of the week, which will answer some of the questions that you may have. Next slide, please, Ryan. I think I want to be very hopeful in this webinar. I want to let you all know that this is an opportunity, a unique opportunity for us to be ambitious with regards to how we negotiate training in colorectal surgery. This is an opportunity for us to negotiate training in the 21st century, how to make it virtual, how to make it accessible, and how to make it better. Thank you very much.
Thank you, Dina. And in the interest of time, we're going to move on relatively quickly to the next slide, which is really just to say, as editor in colorectal disease, that the editorial team have been working tirelessly behind the scenes to try and bring you the very best of all of the COVID-related content. And there will be a dedicated curated collection of COVID-related articles in next month's colorectal disease, with some articles on persistent viral shedding of SARS-CoV-2 in feces, colon capsule endoscopy, coronavirus, the Italian experience, research disruptions, which we've heard Nicola talk a little bit about, and some of the practical tips and tricks about how to set up smoke evacuation, and accompanying videos are also on the website. We will also have some interesting articles in that edition as well about QFIT and its place in 2-week wait as well. So lots been going on behind the scenes to bring you the very best of up-to-date evidence. And we know that as we get going again, and the recovery will bring its own challenges and more data, and we'll be looking at another edition of colorectal disease in September, which will focus more on the facets of recovery and articles relating to that. And we've got some great pieces in the pipeline. So if you have anything of interest, anything of relevance, do submit. Thank you very much. So at that point, we're going to finish the presentations and we're going to move on to the questions. And we're just going to start with a question really directed, first of all, to Ian, and I'm sure all the others will chip in, which is really about the challenges that we've faced over recent times and how we've managed to overcome them, not least because I think it's been in the news, certainly in the United Kingdom, widely disseminated about the challenges that existed at Northwick Park and at St Mark's. And the difficulties that there were there with the sheer number of cases. It was overwhelmed. But yet the guys at St Mark's managed to carry on doing some operating. And there were some particular facets surrounding teamwork, team structure, and human factors training, which I think put them in a very particular position. And first of all, I'd like to hear, Ian, tell us a little bit about what happened to you guys down there and how you managed to take things forward. In particular emphasis on some of the team working and human factors elements that made you able to do things successfully. So that's going to be a really useful model for other units going forward.
Thank you, Neil. How would I put it? Well, I think you're all aware of how London was fairly badly hit. And in fact, the north of London where we are was particularly badly hit. And very early on, we realised that we had absorbed all our critical care facilities, and any hope of continuing on site in the trust, any elective activity would be extremely difficult. And I think prior to any big decisions being made in the trust, we'd already made inquiries about relocating, particularly the cancer surgery, to a separate location within London. The rationale for how we set that up was that we were trying to minimise the amount of risk of introducing COVID-positive patients into this new site. This was one of the big private hospitals in central London. We had to have a clear prioritisation plan. This predated some of the NHS England advice, but very much was in line with some of the prioritisation categories. And there's some ethical dilemmas around that as well. And we took an approach of absolute safetyism, I think that's the term that's been described, where we tried to use as many additional safety measures as is possible, heavy use of PPE. And we thought about the surgical approaches which we might use. We wanted to maintain as high a quality approach to surgery as is possible and try and use the same approaches that we'd been using for many years. Now, to draw back onto the human factors things, Neil, I suppose the thing that hit us early on is if that's the right term to use, we needed to use a familiar environment. We needed a team that was familiar with us. To a certain extent, we took a lot of our own team down with us to this private facility, but already the team that was embedded there was very familiar with the processes, the different sort of equipment that we used, and in fact, it was exactly the same equipment. The environment in the theatre was almost identical. They knew exactly the techniques that we used. The techniques were identical to which we used. And the perioperative care was identical as well. So, you know, they followed a very well-established enhanced recovery program. So the actual environment that we moved into was near identical, albeit the geography was slightly distant. But even though that distance was a bit of a journey, more of a journey for our patients, it's only 20 minutes more in a tube. And the real contrast came, having done that quite successfully, when NHS London restructured and reconfigured how we should deliver cancer care, and we relocated to another site, not familiar with what we've done, not the same team, not the same processes, and whilst they have done everything in their power to make it as smooth a process as is possible, it is just not the same. And I think the human factors play a huge role, and I'm sure I'm not alone in my thinking in all of this. And I'm sure if we're to reflect upon the outcomes in both scenarios, we will see that the initial approach that we used has probably been more successful than the one we subsequently used. I hope that answers your question there.
Yeah, brilliant. Thank you. And for those of you who want to know more, Ian and colleagues at St Mark's have very kindly written this into a lovely article for us, which should be in the September edition of Colorectal Disease. Nicola, would you like to touch on that a little further from the human factor side of things?
Thanks, Neil. And Ian has illustrated beautifully how absolutely fundamentally important it is to think about your environment. It's not just the environment in terms of the level of COVID, but it's also your environment in terms of the constraints placed upon that environment. And we've spoken about this previously in terms of we're asking centres to look at their own resources, to look at their own availability, their own expertise, but also what's available to them there at any time. Because there's no doubt that PPE has varied in terms of how much has been available and whether the right level has been available depending on the different types and also the type of surgery offered. it's about getting things lined up so that you can deliver a system of care at local, possibly regional level, but certainly at local level, where you keep your patients safe and protected, not just from COVID, but also from unforced error. And there is certainly some concern around the country that we will see adverse outcomes simply because people are operating under such pressure. It is unpleasant operating in full PPE. It's very difficult to communicate. With the trainees, we've talked about how this is going to have to be dealt with separately. One of the things the Duke's Club have built into their advice is about preparation beforehand, warning the theatre team that training is going to be taking place, looking at cues and signals of how surgeons and trainees will communicate when things are not going that well because your voice is less used to you than it was previously. So I think it's really about getting those local solutions up. But we also want to look at now going back to patient benefit. And that's why ACPGBI has really said that now is the time to start thinking about doing things a bit more normally. The level in a tested patient is relatively low. And as the population incidence falls, so is that risk going to fall, dramatically so. Because the probability of a test being positive is very small, and probably at the moment in the asymptomatic population, probably around 1%. Difficult to know that for sure. We're just measuring it in healthcare environments. One has to assume that healthcare environments are reflective to some extent, particularly when the incidence of patients falls, of the greater environment. And that then becomes a very different test. I'm going to very quickly, on exactly that point, Neil, take up a question that I've seen come up about why is there a difference between diagnostics and elective surgery? The difference is that the signal in elective surgery is if your patient gets COVID post-operatively, they have a much higher mortality. A patient having an endoscopy procedure, whilst there might be some aerosol generating procedures involved, particularly with gastroscopy, the risk is perhaps lower with colonoscopy. And your patient is not having a general anesthetic and staying in hospital in an environment where they may or may not be exposed to COVID. Thank you.
Thank you. So we're going to move on now to a couple of questions which are very much focused towards training. So I'm going to start with Dina with questions that have come in, and it really touches on the multimodal aspect of training that you've alluded to by using things like web-based resources, videos, and you highlighted the colorectal disease channel as one of the potential mechanisms for gaining educational material. But what are ARCP panels going to think of this, and how do trainees have some form of accreditation for all the additional work that they've put in? How does it get recognised? Dina.
Thank you, Neil. So I think that ARCP panels are going to have to approach ARCP very differently to what they've done previously. And I think that they are going to have to acknowledge the change in the way we have been gaining education and the way trainees have been accessing educational resources. The thing to say to a lot of trainees is that if you do something on a simulator, you can record that and you can still have it on your portfolio as a PBA or a DOPS. And so they should do that. They still count. They should also document all the educational activity they participate in and upload it to their portfolio appropriately. Trainees should not be allowed to not progress because they haven't participated in operative training as we would normally expect them to. They should be allowed to progress based on their competencies and based on whether they're making sufficient progress, irrespective of the COVID-19 pandemic. I think that the trainees that are going to have most difficulty are the peri-CCT trainees, and I think all other trainees will absorb this loss in training time. But it is a really unique opportunity for us to start thinking about how we introduce simulation, how we introduce VR into training at this point in time. So I think use this as an opportunity to think about how simulation training can be improved.
Thank you. I'm going to also throw that question over to Mark as well, obviously with your background with LAPCO, Mark, but also with a view to how that can translate into training for colonoscopy as well, with colonoscopy simulators and such like. How do you see the future unfolding a little bit?
I think simulation's got an important role to play. I really do believe that NHS England, before this crisis really hit us, through conversations I was having, are serious about not only significant increases in capacity for screening, but also for scoping symptomatic patients, and the means whereby we do that through uplifting capacity for training as well, without significantly affecting quality. And they're certainly aware of the potential benefits of having endoscopy leads within deaneries, of the potential for training academies and focusing on dedicated training lists. What I would say about surgeons in training is, which I slightly not disagree with Dina, but just have a point to make, is that physicians in training in gastroenterology have less to be concerned themselves about than surgeons in training, who have to get to theatre and all the rest of their things. They find it much more difficult to get to the endoscopy unit. So there's a greater challenge to be had. So yes, we can advocate that they should be treated equally to gastroenterology trainees, and I certainly believe in that. But I think it's increasingly difficult for surgical trainees to get there, to get the necessary numbers in good time. And there have to be ways driven by trainees to address that problem.
Brilliant. Thank you, Mark. In the interest of time, I think we are going to have to move on a little bit. And one of the topics that has come up repeatedly in the webinars that we've had, and again, it's been mentioned a few times already, is this concept of cold sites. But what exactly is a cold site? How do you define it? How do you maintain it? And how do you staff it? Do you take your own junior staff to a cold site? Do you have to get more from elsewhere? Ian, would you like to kick off with that one?
That's a cracking question, Neil. I can give an answer from the point of view where we took a lot of the cancer work to one of the big private hospitals. They used their own staff, apart from the anaesthetic staff and surgical staff, their own theatre teams. They've got their own critical care outreach. They've got a huge ITU. It ran as best as any hospital in the world could expect for any intervention. There's another private hospital where we're doing benign work, where we've taken our own staff up there. And other than the environment being slightly unfamiliar to many of them, that's actually working pretty well as well. What is the best way of doing that? I don't know. I think we have to wait and see what the outcomes from the benign side are going to be like. But I think trying to disrupt the structure as little as possible is probably the safest and most successful way of trying to achieve that. Now, in terms of what a cold site is, that's going to be very difficult to answer, because what we define as a cold site may not be actually achievable in many places across the UK.
Yeah, Nicola, I mean, is a cold site a hospital that has no COVID patients? Can it be a wing of a hospital? Can it be some ring-fenced wards? I mean, what is it? How are hospitals going to have it?
So this is exactly it. The definition is possibly less important than what you put in place to try and achieve it, and then how you monitor whether you've achieved it or not. So it depends very much on the local prevalence. So in other words, the cases in and around your hospital at any time, the new admissions that are coming in. It probably also depends to some extent on your incidence of new cases in ITU settings within that hospital. Then how much can you separate your services? Can you separate your elective surgery from everything else that is happening in the hospital? And if you can do that in a wing with a separate theatre suite that has access, you can ensure access to post-operative radiology on a cold scanner or some other way of doing it, then you're relatively protected. You may even, with very, very good screening, be able to decide where patients get allocated, even emergency patients. So potentially some sites are using emergency patients on elective wards because they've been screened. And the more point of care tests come about and we have greater confidence in those results, then it may be possible to allocate patients to the right place. The second aspect is staff. We've touched on this already about staff testing. It's going to be particularly important in endoscopy. It's going to be particularly important within providing general surgery services, because there are not many places which can staff purely elective surgery. Many of those are also contributing to emergency general surgery rotas, which are naturally going to have a different level of exposure for those individuals. Ditto the trainees. In the same way that we need to apply things to consultants, we need to apply it to trainees in terms of how they provide it. Whether you provide it as blocks and then you get tested, perhaps over weekends, but I don't think we can really look at the 2 weeks isolation as a realistic model. And then it's about background risk, about what the patients are doing. Are they too adhering to the guidance that we're asking them to in order to keep themselves safe? But a lot of it is going to be about good bed management and making absolutely sure that the COVID footfall in your designated area is as low as you can possibly get it, whether it's from patients or staff. So it's not a definition, but it's a way of achieving it.
Yeah, one of the questions that has come through is about these concepts of cold sites or green sites. Can we really have them if staff are expected to move between them for the purposes of delivering care for various blocks of time, either for emergency care or for elective care? And particularly if we're starting to talk about reintroducing training. I mean, Mark, what are your thoughts? Do you think there's anything that's realistically achievable in terms of having dedicated green sites if staff are moving around?
Again, just going back to my talk, I think, cramp in my leg. Oh, sorry about that. What a time to get cramp. Not one size fits all, and there will be places that can provide capacity and do so safely. And I think you have to think about the bigger picture, about the availability of testing, about the safety and availability of your workforce, about PPE, and about those cold sites, and then say, is this safe to train? What I would say to trainees is it doesn't mean you can't go to your endoscopy units, and there's a lot you can learn there right now about just observing what's going on in terms of having donning and doffing areas, what kind of PPE is being worn for what procedures, looking at the runners that are there, providing human resources to the endoscopy units to make sure that there is a reduced risk of cross-infection, and just looking how they're vetting and integrating the booking system with the hospital in terms of pre-op assessment. So our hospital, for example, is the anaesthetic department have taken over all the pre-op assessment for endoscopy, and they're providing us with the information in endoscopy that patients are COVID tested. And you can go and see what's going on, because let's be clear on this, the trainees are going to find these affecting their professional lives for the foreseeable future, if not continuously, then on a recurring basis as the next, hopefully, well-controlled mini pandemic comes back to live with us every few months or years.
I think you've hit the nail on the head there, Mark, and it really does mean that I need to bring in Dina now, because this is going to be something which is going to be around for a while, because a vaccine isn't immediately available to us to sort all of this out. So this is going to be around for at least a couple of years. Dina, how's this going to impact on trainees, and how are they going to cope with perhaps having to go to different hospitals for, say, ring-fenced periods of time to do all of their emergency surgery block, all of their endoscopy block, all of their elective resectional surgery block? How do you think it's going to impact?
So I think that's really interesting. I think the thing to say is trainees are really resilient. We rotate every 4 to 12 months. We are very used to traveling between sites. We are very used to having to adapt to new environments and adapt to new teams. And we have clearly demonstrated that during the COVID-19 pandemic. Surgical trainees have been redeployed to areas like ICU, critical care, medicine, ED to help deliver services. So I don't see that trainees having to move to dedicated green sites for training is an issue. What I do think is an issue is that trainees are not included in the process. And I think that Mark makes some reasonable comments about trainees should attend endoscopy to understand the processes of donning and doffing and understand some of the things that we may have to adapt to. But if you don't train us today, we won't be available to deliver the service tomorrow. And so senior trainees should be given the opportunity to participate in some of the service delivery alongside training, because most of them are just right at the end where they just need to get their certification or get their CCT. In 6 months' time, they will be part of the consultant workforce delivering services. So we need to be part of that process. But I certainly don't think that there's a problem in going to green sites or adapting in that way.
Sorry, I just want to extend that a little bit more, Dina, if I may, particularly about those trainees who are shielding at the moment. And how do we adapt training for that group of trainees in particular? Because I think we all know trainees who have required shielding in all of our hospitals. And how do we provide for that group particularly?
So they're a really difficult group, and I think that they probably need the most support. So Health Education England have the support programme, which is there to help trainees who are vulnerable, who are shielding, who are in special circumstances. I think that virtual educational programmes, virtual platforms, and regular virtual contact with your educational supervisor, the rest of the clinical team, is really important to continue making those trainees feel part of the clinical environment. Just because you can't have face-to-face patient contact for whatever reason doesn't mean that you can't help deliver clinical services. And we need to think about how training is delivered to those trainees, and I think that will be through simulation at home, virtual reality, and virtual educational platforms. And then I think that we should make them part of the clinical service. We're seeing more and more delivery of telephone clinics or video clinics. We're seeing more and more consultations delivered in a slightly unique way. So we should make those trainees who are shielded part of that process.
Mark, thoughts on that?
I agree with it. And I just hope I hope this is a moment when, the powers that be in not only England, but the devolved nations, take note of, we want high quality endoscopy in terms of training and service provision, and it's going to take investment, and that investment needs to consider the future of trainees. We are certainly looking to try and get senior trainees through the final parts of their training as quickly as possible, and I hope Jeff Smith's announcement through the JAG website in the next week will have some words about that in terms of helping to open those doors for trainees. I think that's the important thing I'll say.
Brilliant. Now, I'm just going to move on, and I'm going to come to you now, largely because this really isn't going to be the end of the story. We've had the first surge, but we've already seen the hospital in Weston-super-Mare closed because of a spike in cases, which was announced in the news yesterday and has been in the papers today. We're going to see surges around the UK repeatedly, and it's going to impact on our services and the training that we deliver going forward for some time to come. How do we go forward and prepare for the subsequent surges, and what do we do? How do we respond? What signals do we need? What monitoring do we require?
I missed that, Neil. Was that to me? Okay. It's all right. This is going to be about the ebb and flow, being aware of what is happening in, again, environment. I keep saying environment, but I do really mean it, that is important. We have to retain a capacity in terms of critical care and ability to upscale again. So just saying everything's going to go back to normal is not realistic. We are definitely going to see pockets, without a doubt. That's, we've already started to see that. The modelling suggests that that will happen. Although a lot of modelling hasn't shown us what we thought, in some aspects it has been correct, and this is one of them, that there will be variation in different places. And in those places, they also need to be aware of how they then prioritise EGS again, and make sure they're still looking after patients with emergency admissions from other areas, but a way of managing their elective work by either outsourcing it, so in other words, involving other institutions, trusts in delivering care to those patients, but not stopping it, because patients have to go to a safe environment in which to do it. It's also a big public relations exercise, and Western Supermare has told us that, haven't they? That actually there's a lot of disquiet amongst that trust about the way people have behaved and how this might have been brought to their door. So the aspects of dealing with the whole picture are really, really important, and we as professionals have to be able to say to our patients that this is a safe environment in which you should come. You can trust us. We've done our best to make sure it's there, and still allow them to come in for care, whether it's emergency or elective, that trust is maintained. Because otherwise we are going to have a far worse situation than what has already happened, and is just so seismically awful in terms of what we've faced.
Yes, I think so. We are, I suppose, going to just touch on one or two additional topics, just because we're running short on time. And Ian had mentioned very briefly about the way in which the London Cancer Alliance had helped organise services in and around London. One of the things that came to the fore in that guidance was the use of the QFIT test, and Mark's also alluded to it. I'm going to ask, QFIT here to stay, or is it going to go away again? Ian?
I hope it stays. If it goes away, it will not be because of clinician enthusiasm for it.
Okay. And Mark?
Yeah, I think like we're saying, everything's going to be different from now on. And I think I wouldn't like to be the first person to announce it, but I think bowel scope is going to be cancelled with respect to screening, number one, and we're going to expand the breadth of QFIT as a screening tool, which I think most of us agree with, and I think it's going to be a permanent change to the way we offer services to 2-week wait patients as well. And then there's a few sort of slightly difficult areas that people think maybe we should be doing a lot more CT colonoscopy for these patients, although certainly risk-wise with COVID, there's probably no difference. And then there's the potential in future, not now realistically, for capsular endoscopy. So that's a bit of a door that's opening. But certainly, like I said, if you're around in 25 years' time, I'll have long retired by then. Then these things will be realistic.
Okay. Another question that's come through, which is regarding the situation that we now find ourselves in, with perhaps low prevalence in the community, better testing strategies available now than there were when we perhaps had the first one of this webinar series. Question asked to the panel, what are your thoughts about reducing PPE after patients had negative test and isolation? Or do you still want to wear full PPE in the operating theatre? Ian?
Well, what I think, it would make common sense that if they've been appropriately tested and the tests are robust, and we can maybe discuss what we think are robust tests at different points in community prevalence, then why shouldn't you just take universal precautions rather than just routinely use PPE? So I think I would feel reasonably safe, provided everything at the start, the input of the patient into theatre stacked up, that I wouldn't necessarily see that it would be mandatory to use PPE.
Mm-hmm. Nicola?
I completely echo what Ian has said, and there are major advantages to going back to universal precautions. without a doubt, in the human factors aspect, there are major advantages to that. In addition to that, it's much better for training, but it is actually about safety. And I think that there has to be a level of personal satisfaction that your own safety has been taken care of. And that's going to vary. It's not something you can tell people. It's something that they have to be comfortable with. And the trouble is, it's always the unseen aspect that you don't know about. You don't know about all of your theatre staff and what their social circumstances are. You don't know who's looking after a very infirm elderly grandparent who they may feel that they need to shield a little bit more strongly, that it's not just about their personal risk, it's about the implied risk of delivering COVID to somebody else. Likewise, there may be some people who have undeclared reasons who do not want to be seen to not be working, but actually feel that they have an increased risk personally, and they should be allowed a level of choice. And so actually nationally, we have to make absolutely sure that we've got sufficient PPE available, not just for when the next surge comes. So it's not just about stockpiling, and stockpiling is going to be important, but it is important to make sure it's there for the next surge. But actually we have the individual healthcare worker, surgeon and others, endoscopist, theatre worker, it doesn't matter, that they have to have access to what they believe they need. And that's good education, good knowledge of what that patient's risk is. It's not just a surgical imposition, and we mustn't forget that.
Mark?
Just to echo what they say, but also to say going forward that it's likely that when problems occur with COVID in terms of spikes, they won't be unlikely to be national, especially when we get a robust track and test procedure going, that it's likely that regions, cities, that sort of thing will need to look at themselves. So be aware of where you are in terms of your training and service provision, because it won't be the same in every town.
And Dina, the aspect of PPE and training had been touched upon by Nicola. I mean, from a trainee's perspective, is there any particular desire to move away from PPE for that aspect, or is there still a sense of wanting to protect themselves with the full PPE?
I think that trainees have had a lot of anxiety around PPE, and I think certainly they probably would want full PPE unless we have robust measures to say this patient or the risk is low. I think that in view of the fact that PPE is still being employed in a lot of trusts for operating, and full PPE is being employed, that we have to think about the communication that trainees and trainers have prior to the operation commencing with regards to how they may communicate to say, I'm in difficulty, I need you to take over, please stop. So I think that the way you communicate with your trainer and the relationship you have with your trainer changes as a result of PPE. But I don't necessarily think that's a bad thing. I think it encourages a discussion pre-operatively about exactly what is expected of you and what you expect of your trainer. So in some respects, PPE has helped us develop better relationships.
And that really comes back to a lot of the work that was done over a decade ago now through the LAPCO and the LAPCO training the trainers function, which Mark was very much involved in, as were many units around the country. So we're coming up to the final part now. Just last question, I suppose, before we come to the end. And one of the questions that's been asked is now, as we're getting towards a situation where things are less burdensome in terms of COVID-19, and we're starting to take on doing anastomoses again, what is the role for defunctioning ileostomy, considering the fact that we've got virus shedding within luminal content? Is it something that we should be doing? Should we revisit when we need to do it or not? Very quick answers. Ian?
I've never really been that convinced about the COVID and the GI tract issue in terms of anastomotic healing or any other things. I don't doubt it's there. And I believe there are pathological reports that suggest that people that die and get autopsies have got GI problems there, but hang on, they died. So in terms of anastomosis, I think there are far more factors involved in the success of anastomosis than purely COVID. And if you've done everything right at the start, then it's less of an issue. And if you're going to be doing a COVID positive patient, you're probably in an emergency situation. And in that situation, you're going to dictate, that situation itself will dictate whether you do an anastomosis or not. So I will continue as we have been doing before, prior to the COVID pandemic, and we'll divert as I have been doing before, which is predominantly total mesorectal excisions or any concerning anastomosis at the time of intraoperative testing.
Okay. Nicola?
I agree with what Ian has said. The whole point is that we're moving back to a level of normality. We're operating on patients on the understanding that there is low risk as they possibly can be, and we want to be offering them the same level of outcomes. Emergency patients, I still think all the reasons Ian's outlined, it would be crazy to be doing anastomoses in very sick patients, just as it would be crazy normally. But there's a time to move back. I also think it's something you need to discuss with patients. Patient-centered care is really, really important. And the trouble is anastomotic leaks still cause incredible morbidity. So use everything you can to reduce that from what you already know. Watch for it very, very closely. Make absolutely sure that salvage is available to your patient should they need it, and discuss it with the patient and what their preferences are and their personal risks are. I also would stress that it is an emerging field, that we've still got data coming. Some of us are aware of data that has started to be collected about why there might be additional risks with COVID, but it doesn't necessarily apply to this very elective cold setting where we're trying to offer elective surgery. But a space to watch.
Brilliant, thank you. I think on that note, what we will do is we'll wrap things up now because it's just gone past 8 o'clock. We've had our hour. I would like to thank all of the panelists for giving their time this evening to answer the questions that came through from the participants online. And I would like to thank all the people who've dialed in to watch us and on the webinar this evening, and I hope it's been educational and informative. And finally, I'd like to thank the Royal College of Surgeons of Edinburgh for facilitating this webinar. Thank you very much.
Thanks,
Have a good
everyone.
evening, everyone.
Thank you.
Bye-bye.
Thank you all.
Bye.